free to introduce yourself in the chat yeah, just who you are, where you're from, and anything that you love about this season of fall that we are in. So thank you. And thank you again, everyone, for joining our monthly PFCC Partners Community of Practice workshop. My name is Lindsay Galley. I'm the Vice President of Programs at PFCC Partners, and happy to be with you all today. We have a great presentation for you by our partner, Kate, so we'll get to her introductions in just a moment. We are recording. This session will be added to the PFCC Partners YouTube channel, where you can also find all of the community of practice workshops over the years. So if you are ever inside on a cozy fall day and would like to learn about some really interesting things going on around the country, around patient-family engagement and patient-family centered care, you can check all that out there. We do have live transcript available. I think I need to turn it on, but I can't see it right now. Give me a second. Or maybe Naomi, if you could help me out with turning that on too. It's not showing up for me, but we will make sure that that is available for all of you as well. All right. So really quickly before we get to the presentation today, for anyone that is new to PFCC Partners, this is really what we're all about. We have a vision of a health system transformed into one that works with people and through communities as a partner in their well-being. And I think that you'll see that we share this vision with our presenter today as well. So really excited about this presentation. Our mission is to catalyze system improvements by centering the human experience of healthcare, and we absolutely recognize the critical role that patient-family engagement must play for every effort at delivering health equity, inclusion, diversity, collaboration, and solution-focused. I think we all know that the U.S. health system is a really complex place. Its systems are sometimes difficult to navigate and even more difficult to change. So PFCC Partners, we believe in a system that centers care and care processes on the people. And with that, there's potential to reduce complexity and advance the culturally humble, equitable healthcare system. And we do that at PFCC Partners by opening space for patients, family caregivers, and community voices to drive improvements in this complex healthcare system. We know that voices are a huge catalyst for improvement and systems change, and our entire team has decades of passionate experience partnering with healthcare systems and leaders, engaging people with lived experience in their efforts to improve. So yes, we work to open those spaces within those systems for patients and family caregivers to drive improvement. And we do that through the PFA network. So the PFA network is a national network of patients, family caregivers, and community members who fill those spaces with their impactful stories and insights. The PFA network is continuing to grow. We have such an incredible community, offer skills development opportunities, and provide a variety of engagement opportunities for anyone with lived experience who wants to jump in and share their perspectives, experience, and voice to promote improvements in healthcare. So happy to share more information about our organization and the PFA network with all of you in follow-up and in the chat. But without further ado, very, very excited for our presentation today. We are joined by Kate DiBartolo. She is the Senior Director for the Conversation Project by the Institute for Healthcare Improvement. This has been a really incredible project that I've learned a lot about over the years, and so excited to learn more today. The topic for her presentation is engaging older adults in developing patient materials. So we know a priority of the age-friendly hospital system is empowering patients to actively participate in their health journey. So this workshop presented by Kate will introduce you to the My Health Checklist and the process that the Institute for Healthcare Improvement, or IHI, took to co-design this innovative tool with older adults to maximize their medical appointments. So at this time, I will pass it off to Kate. And Kate, if you'd like to introduce yourself and get started with your presentation.
Great, thank you. I'm gonna take a moment to just make sure I get my screen up for you all.
Okay.
Make sure that that is sharing. Do you see the in presentation mode?
Yes, looks good.
Okay. Well, it is so nice to be with you all today. I was writing in that I'm calling in from Northern Virginia. I used to say DC, but we just moved from DC a few miles over the border, and my 6-year-old always corrects me that I'm in Virginia. But just lovely to be with you all today. I have been at IHI for over 17 years, and so our overlap with PFC partners over those years has been wonderful. I'm just excited to be here to share with you some of what we've been learning about creating patient-facing tools or public-facing tools. And so while a lot of my work has been over in the conversation project, today it's going to be a little bit more about my age-friendly hat. And I will try to keep an eye out for the chat or also ask Lindsay for your help with that. But the age-friendly health system movement that is part of IHI, as well as the Johnny Hartford Foundation, the VA, the Catholic Health Association, the American Hospital Association, there's a lot of groups that are trying to work on making the United States health world more age-friendly. And we have 4 pieces of content that we've identified. I'll go over those forums in a little bit, but kind of 4 key areas that we're trying to work with thousands of health systems on. And what we started to hear is that people wanted help with helping patients be a little bit more prepared. And then patients also wanted to feel like, okay, if I'm interacting with this more age-friendly health system, how can I do a better job with that? So I wanted to share a little bit more about that because we know that for staff, they often get a lot of their satisfaction through delivering good patient experiences. They don't want to feel that they're providing feudal care or that they don't understand what somebody wants, or is this even what matters to this patient? And that adults really want kind of kindness and respect from their team. So we know that it's kind of two-way conversation. That's what My Health Checklist was meant to foster. And so I'm going to share with you a little bit about the guide. And if I have a copy of one right here, this like a toolkit. When I'm talking about a guide, it's free to download on our website, and I'll show it to you. But I mean like a little workbook, if you will. And this is something that we created. It looks nice and polished right now, but before we got started, some of the tips that I wanted to share is we created an options document. We knew that we'd been hearing from health systems that they wanted something to engage the public. We heard from the public that they wanted something to get a little bit more prepared. And we laid out kind of what is it that we think we're going to create, so we could even share those options with people that are in the network with us before spending a ton of time creating a guide and saying, we did it for you. We wanted to lay out, here's what we're planning to do, and get feedback from older adults, family caregivers, clinicians, people in the age-friendly health system movement. And I just really want to reiterate this idea of not spending too much time starting to build something until you've confirmed your kind of proof of concept. We then started to work on different drafts of the document, kind of in a Word document version. There are some placeholders. Here's our idea. This is how long we think it's going to start to be. And we went through over 10 different drafts easily. And at multiple stages, we were getting feedback from older adults, caregivers, like family caregivers, and then professionals that are working with older adults to get a sense of, is this the right language to be using? Are these questions that would be helpful to you as the clinician to be sure somebody's answering? Are the examples that we've included useful for people? We got it down to a fully laid out version where we felt like we've got, I think many cases somebody would have gone live with the version we had. We had it laid out with graphic designers. We had pictures chosen for the front. We were ready to go. And then we went to 2 focus groups, where we went specifically looking for low and middle income older adults, and then a second focus group of low and middle income caregivers of an older adult. This was run by a separate organization so that we were not in the room. Nobody felt beholden to tell us that, what we would want to hear. But it was really helpful to get final tips. Like if this were in your hands and you were receiving this at a doctor's office, or that you found this at your pharmacy, what would your reactions be from people that we didn't know? They didn't have any affiliation with age-friendly health systems. And were from all over the country. That was important for us to be sure that we weren't accidentally reaching out to kind of our friends and family, if you will. And we got feedback, I'll share more of it, but everything down to like, there was one of the pictures on the cover where they said, we've seen that guy on too many pieces of collateral that other groups are using, so you might want to pick a different stock image. And then we worked on translations of the materials into Spanish, Portuguese, and Chinese, and we've worked to kind of cross-check and make sure the norms and the language there are in good shape as well. So that's just like a little bit about some of our creation process. When we were asking people for their feedback, we created we wanted to make it as easy as possible for people to give us their feedback. So let's say we sent out a draft of the guide. We would say, we're happy to have a phone call with you. You can reply in an email. You can do track changes in the Word document. And we created a form that they could fill out if that was the easiest way to do it. And these are the kinds of questions that we were asking, kind of what works well and feels useful, what would you change or remove, what would you add? We were trying to come up with specific examples for each of these M's about what matters: medication, mind, mobility. So we were asking people to give some examples that we thought would be good, or do you think that people would see themselves reflected in these examples? And just asking people if there's anything else they would like to share. It was through these prompts that we were able to get a lot of the feedback, rather than sometimes standing it saying, oh, what do you think? Let us know. People take a look at it saying, hey, it looks pretty good. When we specifically ask for what would you add, or what would you take out, or what are some examples that you would include, that's where we started to get really helpful feedback, and making it easy. So you don't have to fill it out in a form. You
Wait,
don't have to do this in an email. I'd be happy to call and chat.
wait.
So, yep. Do I hear a question? Oh, maybe it was just an unmuting moment.
Yep.
And then I'll take a quick peek over at the chat to see if there's anything that I can help with here. I don't think so. Oh, thank you for including the guide there as well. So a little bit of background on what the tool is and isn't, and kind of its purpose. It is meant to be kind of a comprehensive guide to help older adults reflect on their health and well-being and assessing all aspects of their health. It's kind of centered on these 4 M's that I was mentioning. It is not meant to be a tool that's filled out during an appointment, or to take the place of any intake forms or questionnaires that a health system might already have. It's more of a workbook for at-home use, self-reflection, getting to feel prepared for upcoming appointments. So you can really kind of review it at home at your own time, and may help be better prepared for an intake, materials at an appointment. So the 4 M's that we will go through that are part of age-friendly care. The very first one is always what matters. So we give open-ended prompting questions to help older adults think about their situation now, what's going well, what could be better, and what do you want your provider to know, or what questions do we have? And then for each prompt, we give some examples. So the kind of some ideas section under each of the boxes to get somebody thinking. These were very carefully crafted from feedback from the older adults, caregivers, healthcare team members, where we were trying to share a range of life experiences. So if somebody was retired or not, various income levels, housing needs, different physical ability levels, if somebody's able-bodied, people who are frail. So really trying to ground this with what matters, and then have a similar spread for people across the different M's. So in medication, it's supporting kind of what it looks like to track medications, but goes beyond just prescription type things. We're prompting people to talk about their over-the-counter medications, the herbal remedies they're taking, maybe talking about concerns for things like cost or keeping track of different medications. In the mind section, we're talking about prompts to help people reflect on potential dementia, depression, as well as anxiety or loneliness. And again, the health systems are all working on these same 4 M's. So one of the goals is to help them kind of be prepared in both ways. And then the next one is around mobility. So this is around moving around the home out and kind of going from place to place. So in your home and outside, as well as from going to place to place. And you can see those same questions, kind of what's your situation now, what's going well, what could be better, and what questions and concerns do you have? And on the last page is kind of where the checklist is, where we suggest that people kind of pull it all together, bring up their top 3 things for an appointment, kind of recognizing that there could be some time constraints. They may not want to fill out every single page, that's okay, but we want anybody to be able to pick it up and think this could be for me. So throughout the guide, some of the feedback that we got that was really helpful was kind of addressing issues that might feel embarrassing, but once you see them offered, it kind of gives permission to go there. So we have examples about loneliness or things costing too much, bladder control, relationships and intimacy. We wanted no gender binary language, kind of no assumptions about family relationships or sexual orientation, to really include language and imagery that's reflective of as many types of life experiences as possible. And that's where getting feedback from people was really helpful. And how we did this kind of in co-designing with older adults. So all of those drafts, you could have seen something that looked like this in the beginning, but getting to those repeating 4 questions, breaking things down from one person's suggestion on cardiac prescriptions to talking about my heart pills, or what is the language that's the most kind of common denominator that would be useful for everyone. And by the time we got to those focus groups, we got really positive, there were a couple of tips, but we got really positive reviews from people. And so people starting to say like, yeah, I'm in this focus group, but how do I get this for my brother? I think he would really want this, or I would love to do this. And one of our focus group members became part of our What Matters advisory group because she was using it and she loved how it went. I'm going to pause for a moment now just to see if there's any questions before I jump into a little bit of kind of why we found this all to be important.
Hey, I have a question.
Yeah.
Sorry, let me put my camera on here. So my sister came home Tuesday from the hospital. She had a partial foot amputation, and they sent her home with a little packet of things. But it was so unclear what she was supposed to do when she got home. And now we're calling the doctor to say, is she supposed to be off weight bearing? Is she supposed to, so we don't know. And something like this would have been good because myself personally, I need to see this to remember this. I can put it in my calendar. If I don't see this, then I'm not going to see this. So something like this comes very useful. So I think this would be an awesome tool for sure. But
Thank you so much. It reminds me, I remember when I was younger I was going to see my pediatrician and my mom was like, and tell her about your knee pain. I was like, what are you talking about? I don't have any knee pain because I didn't have it in that moment. And she was like, you have been complaining for your entire field hockey season about your knee hurting. I was like, oh yeah, I forgot about it because on that day, that wasn't my main problem. But having something that you can kind of keep, it doesn't all have to be done the day before. This could be something that's kind of like a running list you keep track of, can review over the course of time, or what you're describing, Roger, of a specific moment, like a specific discharge or an illness that we're managing. There's like what matters about the surgery recovery. I want to get up and moving, or I want to be able to move independently in my home. There's questions about medication, the mobility needs of that. Should I be weight bearing? Should I not? Oh, when I take this medication, it's making me a little dizzy and I'm worried I'm going to fall. So these 4 M's are kind of prompts to organize the thoughts of the conversation, especially because we know the providers often feel like, I got 10 minutes. What do you really want to talk about? Because they do want to help, but it helps them to know what the big topics are to cover.
And Kate, I don't know if you see the chat, but there's also a question in there from Anju who says, is there a separate tool for caregivers too?
There is not. They are often recommended to use the same one, but let me show you. You know what? I don't think I included every single page, did I? No, there's an inside page. It has a little bit of information of like tips for completing the guide. You can do it in any order. You can take it in small pieces. You can talk to somebody about your answers. And there's a section of if you're helping somebody complete the guide. So talk about why this will help. You might say, I want to make sure we talk about what's most important to you so we can, have a more useful conversation with your provider. Really focusing on what matters most to the person you support. This is a conversation about their care needs and goals. So there's some tips if you are a caregiver for somebody, helping to facilitate it. In our conversation project work, we have a lot of other guides that are a little bit more about life with a serious illness or planning for end of life care issues. We have recommendations. We've got tools for caregivers of like if the person you're supporting can't speak for themselves, what would be some additional tips? This is kind of our first pass at the My Health checklist for older adults. I think that there could be future versions, and this is part of what we're trying to see what would be helpful or not. But my hope would be that caregivers could see themselves kind of reflected in it, or these could also be some prompts that a caregiver could look at this themselves and ask the questions verbally or have them be part of a conversation. It doesn't all have to be a sit down, let's talk about every single thing in here, but you can use some of the questions to go through as well. If it's okay to move on, I just want to share a little bit about kind of what we're seeing these conversations lead to, some of the testing that we've been doing with health systems, and then also wanted to share a little bit about messaging research that we've learned about trying to engage the general public that I thought might be helpful. So for us, we know that prioritizing these conversations can lead toward, better care alignment, that understanding and responding to what truly matters to an older adult is the key to delivering effective care. So that is the principle upon which all of the age-friendly health system work is based. And that by asking about acting on their specific goals and preferences across each of these 4Ms, the healthcare providers can align with what people actually want, which sounds so obvious, but we know that that is not always the case. And that when we are providing, especially for clinicians to be providing care they think is discordant with what somebody wants, there can be a lot of moral injury on both sides of that. So that's one of the things that we're trying to get to here. That we can try to achieve better outcomes, provide higher quality care centered on what's most important to that person. It's really helpful for a provider to say, okay, what matters most to you is dancing at your son's wedding in 2 months, and we need a plan towards that. That's where understanding what matters to somebody can make a really big difference, because each of their patients may have different goals and they can have different recommendations based on that. The third is that these conversations really help build trust, better relationships, which, as you all know on the line, can be kind of a cornerstone of all care, and just helping older adults and caregivers be more activated and prepared. So we know that over the last few years and some messaging work that we've done in the advanced care planning, hospice, palliative care space, that when patients feel heard and listened to or important, they feel better in control. They feel more activated. And so we see this as kind of a self-fulfilling prophecy of, if a health system is one of the ones helping distribute this or engaging people earlier on, that can help patients earlier. And just kind of re-emphasizing that these conversations support better communication and connection between individuals and their healthcare team. So the way that different providers have been using this has been kind of fun as we've been working with different institutions that are trying to bring it out. A lot of them are doing this personally. They're kind of saying, hang on, take off my professional hat for a minute. Maybe you have an older adult in your life. Maybe you are the older adult in your life. Like, this is a great way, especially when engaging patients, to say, like, I did this myself, or I just went through this with my parents or with my neighbor. And so that kind of ability to walk the walk, like the I voted sticker, and to exemplify this ourselves can be really helpful. Different systems that are sharing it with staff internally, so kind of a focus on getting staff prepared for it. So lunch and learns, grand rounds, newsletters, HR, introducing it, that type of thing can be helpful. And then there's different settings where kind of going direct to older adults, whether that's giving out physical hard copies, sending a link to the guide in inpatient, outpatient, all these different settings. There's ways that it is getting out to people. Some people have a much easier budget and job printing. They might have in-house printing in their facility, and this is an easy thing to incorporate. For others, they know that printing is going to be really hard, so they're working on getting it into patient portals. I think that what we're wanting to watch for with systems that are working specifically on patient portals is being sure that we're not only reaching a demographic of older adult that has the technology ability or access to be able to do that, while also acknowledging that for some systems, that's going to be the best way that they can get the word out. And then when we asked different older adults where they would want to receive this message, that was really helpful to kind of see what their suggestions were for where they would want to get it. Some of them, yes, it is the healthcare system where they want to get it. For others, it's more community-based organizations. It's been fun to see groups working with kind of congregations, AARP, libraries, other kind of settings to help introduce this so it doesn't feel like it's only a medical situation. There's ways to tap into the important days that happen in the year, what matters to you day, National Healthcare Decisions Day, Caregiver Month, all of these are good kind of programming, especially for corporations, maybe who run senior centers, assisted living facilities, kind of neat to see what they're doing. I will say that for many older adults, the goal, they were saying that the printed is king. They would rather have this nice little booklet to put in their bag, to have pen and paper. We tried to make the font large enough for people to see the contrast, dark enough to be able to read. There's a lot of thought that went into what it looks like as a printed guide. And when you see it in a Word document, it looks like it's 12 pages long and that feels really big. But when you actually see it laid out, it doesn't feel as overwhelming for people. I'm just going to check the chat one more time. See, will these questions be provided prior to the appointment or? Yes, so it's really interesting to see how different groups are trying to think about how they're going to do this. And are they inpatient? Are they the geriatrician's office? Is this a pre-surgery appointment? Like, I think there's so many different types of settings that for some people it's going to be upon admission or upon discharge or a general practitioner's office who does this with everybody at their Medicare wellness visit, or here's something we're mailing out to you ahead of time, your appointment's in a month and we'd like you to take a look at it. So you can be better prepared and we know what you want. So most of the institutions that are doing this are kind of setting their own goals of what is useful to them or what the pain points are that they're seeing that they want to address for. They are wanting to be careful about not introducing it right before an appointment and asking people to do it in the waiting room, especially if that takes the place of other intake forms. But there's no limit to how it can be used. They're all freely available. And as I mentioned, they're in multiple languages. So we may see that there's other languages we want to add, but that's something that people have been doing as well. Let me see, I see a couple more questions. Oh, a recommendation on how often the questionnaire is repeated. I think, Andrew, that would depend on the person whose health we are discussing. There are some people who looked at this and we got feedback and they are very healthy older adults who go to their annual physical once a year and that's about it. And so for them, it's going to be an annual thing. They don't have that many things changing. There could be somebody else who's had a major episode or a serious illness or something that's kind of temporary, but they have more appointments and they might be looking into it. I could imagine for somebody who has multiple specialists or issues that they're working on, they may be going through it more regularly. But I would love your general feedback on what you could imagine being the case there. So for providers, if they're doing this, kind of thinking, it's okay, asking and listening, what is somebody telling me about what their top 1 to 3 things is, trying to think about what can I do in this appointment to address the issues, with whom can I share the information? Is there anything that's kind of coming up regularly that we're hearing across all of our patients that maybe we can get ahead of? I think about when I was having a baby, how I was invited to create a birth plan. I was asked proactively by the OB office, like, as you think about your labor and delivery, can you tell us what matters most to you, how you want that to go? And with the understanding that not, medically, not every single thing might be feasible. Some people are going to have crash sections. Some people are going to have other issues. It may not all be exactly as you wanted, but the providers want to know what matters most to you so they can make that a good experience. And my OB said that they took the 10 most common requests or issues that were coming up, did a quick literature scan of it, and decided to make that the standard of care for everybody. So it wasn't having to be individually asked for anymore. So trying to think about, like, who else could I share this with that might be helpful for this particular patient right now? What other team members do I need to have? But also, what else might we want to be changing based on the feedback that we're getting? And then trying to think about how can I remember what we've heard? So how am I going to steward this information so the next time the person comes in, I'm going to be able to reference it. So is it that in clinical notes? Is there a template to capture the conversations? There's one system that used kind of like a smart phrase in the sticky note section of Epic, prompting them to ask what matters most to somebody. And when the patient discharges, the note disappears, so they have to ask again at each admission, rather than it being in there from somebody else's note many times ago. So trying to think, you can also capture what's important to somebody around, like, oh, there's that wedding that's coming up, or there's a graduation, or the what matters is having weekly lunch out with the daughter. So trying to understand a little bit more about what's going on with somebody and being able to look at that regularly. And then taking action. So reviewing the care plan with the older adult, making sure it aligns with what matters. Do we need to adapt anything? Connecting with the right care partners or care team members. Asking for feedback from the older adult of what went well, what could go better, surveying them to kind of see how their care is matching what matters to them. Using this as a chance to really strengthen relationships, acknowledging out loud with older adults that many people lack trust in the healthcare system, and talking about the issues with colleagues in the context of your community, kind of making sure that we're asking every older adult about what matters to them and about their forums, not only those who look like or talk like you or that you're most comfortable with of your patients, but really making sure that this is not furthering inequities of care by only approaching certain people and doing it to everybody. And again, this idea of spreading what works, identifying and acting on common responses. So if many inpatient older adults say they're getting hungry at night after the cafeteria closes, can we work with dining services to create a late night food option? So I think it's really just showing that you care about people, not just as patients, but building the relationship. This is a tool that can help us build that. And so if it is of interest, there are some other resources that we have. We have a guide for clinicians specifically about how to talk about what matters. We've heard from a lot of clinicians that even that one sentence feels awkward to them, or they don't know how to kind of get around that. So we have a guide for that. I mentioned some of the conversation project materials. There's one about living with serious illness. It never mentions end of life issues. We have some that are a little bit more end of life care centric. But really about how you want to live your life through the end. And I mentioned the one for caregivers of somebody with Alzheimer's or other forms of dementia. We also have one for caregivers of seriously ill children. I'm going to pause again before jumping into some additional messaging research, just to go back to like the forums, this tool that we've created, questions about how it was created. So let me just see what else has come up in the chat. How can patient caregiver provider use this in a way of continuity of care, especially if seeing many specialists? Can I throw that back, Naomi, or to others in the line, how you could imagine using something like this if somebody does have multiple specialists? That's part of what we're starting to test out with different health systems now.
Yes, I'm gonna think on that and come back when we do Q&A, if that's okay.
Yeah. I think one thing, my work has been over in the end of life space for the last 12 years. And I want to name very carefully that this What Matters document or emphasis here is about all of life. What matters most to somebody might include some advanced care planning, but it is not expected that that's the intention of it. And so, but one thing I have learned in the end of life space is how do we steward this information as reliably as we do allergy information? How inappropriate it would be to ask somebody, do you have an allergy? Yes, no, and never really follow up on that. The same way we might ask, do you have a healthcare proxy? Yes, no, and we don't follow up on that. This is where I think working with IT and the systems that are on electronic medical records, kind of learning what others with the same platform are using, what systems are working well, so that information can follow people. And so somebody's wishes can change, and that can be updated as well. I remember hearing from a gentleman or it was from a physician, but he had a patient who was older. He had a lot of health issues. He'd made it very clear that, if something got more complicated, this man did not want a lot of intervention taken. He wanted comfort measures, not treatment measures. And yet he was admitted to the hospital in the ICU, full code status, and his doctor was rounding and was like, "What's up, Mr. Brown? Like, I thought that we had a plan, and I just want to be sure everything's going the way you want it to." And he said, "We did. But my first great grandchild is due in 2 weeks, and I will do anything I can to meet that baby, and then we can go back to the other plan." And it's a perfect example of like, we need to be able to capture what matters to somebody. And it can be in that moment, what matters to somebody might be different than what they said 3 weeks ago. And that's okay. That's important. That is still how we want to be kind of serving them as best we can. Thank you, Lindsay, for putting the link in the chat. My hope with that link is that people will take any of those language translations. You can use them. You can post this on your site. We don't have there's no charge for it, but we specifically, if you've ever been to IHI's website, usually you have to give an email address or kind of go behind a little wall of providing information. And we did not want that to be the case for this particular tool. So my request would be, if you're going to post this on other places, that you link back directly to the guide that's there for version control issues. So it helps us if we make any edits to the guides, that you'll have the most up-to-date version by linking to it. The other thing that we're working on right now is creating a co-branded version where you would be able to put, generously distributed by, and maybe it's your local AARP chapter or your health system, something to give credit to whoever's doing the printing. What I would love to share a little bit more about as it relates to this idea of engaging older adults and getting content and kind of understanding what language we have been learning matters most, how to get to the what matters concept with people is based on some work. Again, this comes a little bit more from living with serious illness, or are people willing to talk about what matters to them doing advanced care planning, that was done by the Massachusetts Coalition on Serious Illness Care. But it is with national scope. So this group did a lot of surveys. They oversampled Massachusetts to see if there was any difference. There wasn't. So this is really national in nature, even though it was done by Massachusetts, where they were looking at the reasons why people do or don't take action on advanced care planning, talking about what their wishes would be for care through the end of life. And because a lot of providers were kind of saying like, "Oh, well, that person is XYZ demographic. They just don't do it." And we knew that that wasn't quite right. And we also knew that there were or our theory is that there were different reasons for why people did or didn't take action, and that they shouldn't be treated all the same when it comes to messaging. And so you can see on this left-hand side, these are the kind of the peachy pink color. There's two different kinds of consumers that do take action in talking about what their wishes would be and approaching serious illness, but they do it for two very different reasons. Some are doing it because they're worried. Maybe they have been a caregiver or somebody who's incapacitated in the past. They may identify as having a disability, so they're kind of taking action because they're worried, which is very different from the self-assured person who really confident in managing their healthcare. They expect the healthcare system to do what they say, which is an interesting kind of demographic thing here too, but since we know it tends to be the oldest and the most white and the least likely to be low income, like who has trust in the healthcare system that, yes, I said that I wanted this, I believe the health system will do that. So those people are taking action out of kind of assurance. But over on the right in the blue are folks who are not taking action, and it's for some of those same reasons. Some people are really disengaged. They may be seeing that somebody's wishes were not honored. They have a lot of trust issues in the health system. Why would I do this and put all this energy into it? Versus people who are really confident and think, "Oh, my kids are going to know what I want. My doctor knows what I want." They feel that people will do what they want without talking about it. Those are very different reasons for not taking action. So we don't want to just assume somebody does or doesn't based on that. And so we looked at messaging language to see how it kind of tested across the different sites. And you can see the larger the circle, the more it appealed, and the blue appeals, the red doesn't. And these are the different consumer segments. So over to the left are the two messages that really worked for people. This is a chance to gain control. At a time when things may feel out of control, here's a chance, a little conditional control. And rather than leaving things up to chance, conversations clarify. So that, I think, very much fits with this What Matters checklist. And to demand shared decision-making, that we can have a say in our care. that honestly our providers want to know what matters most to us. They can make better recommendations for us if they know what our goals are. Those two concepts really work with people across all of those different consumer segments. What didn't work as well is the idea of, this can give you peace of mind, or it's a gift that you can give to your loved ones to think about it. I want to say that we used to use that language on the right, that those messaging concepts on the right-hand side. Caring means learning about them, trying to engage caregivers to do this. It's just now that we know better that for some people that actively turns them off. They think, well, this doesn't really give me peace of mind. I've still got bills to pay. This doesn't lessen my burden. I still have a lot of other things going on. Or that sounds like foamy marketing messaging. This idea of to have a say in your care, to demand shared decision making, and that conversations clarify really resonated across all different segments. The other thing that we've learned is not to use myths when trying to explain something. So this is an example of, in the NIH, this idea of like myth, palliative care is for people who are at the end of life, like truth, it's not. People remember the myth. So if we're trying to show the difference between palliative care and hospice, and we say, don't worry, palliative care is not hospice, people remember the hospice part. And so really trying to be clear about what is it that we're trying to convey to somebody. And so we've been part of work nationally with the serious illness messaging group. There's a website here, and everything I'm sharing is for you to take and to use however you would see fit. But they've worked on messaging language that have done a lot of focus groups around the country, making sure this language works for people. I'll put an asterisk in that for where I haven't seen it work. And so for advanced care planning, it's talking about what is advanced care planning? Why would we do this? Tell your doctors what matters so you can get the care that's right for you. Treatments only work if they work for you. We'll figure this out together. That's language that really resonates with people. If it's for palliative care, this idea of kind of an extra layer of support, or you can live well while living with, insert the serious illness that you have here. At any stage of illness, we're here. This is a team for all of your concerns, or it helps your doctors talk to each other. And then with hospice, trying to describe what hospice is at all of these different kind of stages, and you're not alone in this, we'll meet you where you are. So these are language that really work when describing this to individuals. And they're built on kind of messaging principles of talking up the benefits of what it is you are offering. In our case, when we were working on advanced care planning, we don't actually lead with dying or with death. This is, again, about how do you want to live your life through the end. This is the way that things improve people's lives, rather than trying to scare people with negative stories of, oh, look at this bad situation when somebody didn't do the thing I'm telling you to do. That doesn't really work for people. So having positive benefits, making sure that we're presenting choices at every step. At every stage of illness, we have choices. I hope to never hear like there's nothing more we can do for you, Miss Jones. There may not be curative treatment solutions, but there is always care that we can be providing, and comfort that we can be providing. To use stories, using those positive aspirational stories. We don't need to bombard people with statistics. They don't tend to remember them. And so giving examples, especially if you start using this, or that idea of exemplifying, here's what it was like when I did it myself, or when I was doing it with somebody in my life. Here's what I've heard from a couple of patients. You're not going to share an individual person's name, but you can share kind of general lessons of what you've been hearing, or, my patients who have this same issue, here are some of the things that come up. Making sure that we're inviting dialogue and not just once. So we're trying to talk to people regularly, that we are invoking a new team that includes patients, people who matter to them, healthcare providers, community members. You notice I don't say loved ones. We've learned that loved ones can be a really charged term to use for people. Many people are caregivers for people they don't have an awesome relationship with, or there may be kind of fraught tension in the past. And then I've added one here about how imagery matters. So throughout all of our materials, I'll try to hold it up a little close, or if you go to the website, you can see the people are looking pretty positive and aspirational, without looking too cheesy. That was our goal, trying to avoid it looking too cheesy. But what we've learned, and you can imagine from all the pharmaceutical ads that we see from, cancer companies where it's got people riding a bike and having a great time and eating ice cream and being with family and friends. People want to see somebody living a life that looks like that looks like a good time. And when we have pictures that look like somebody's having a really difficult conversation, they think like, ooh, that looks tough. I'm not sure I want to do that. I don't want to sign up for something hard right now. I've got enough on my plate. And so we've learned that with imagery that neutral reads as negative for people. So you don't need somebody like laughing hysterically and jumping on trampolines and doing absurd things, but like a pleasant demeanor and looking content can go a long way. And not having a bunch of like hands being held and people walking in a sunset or the backs of people on a bench. We used to have those same images, but the imagery really matters for helping people feel like this is something I want to do, or that looks like a good time. And that the messaging of we'll figure this out together really just works so well across all different demographics for people. So with that, I just want to pause. I put my email address here and was just hoping that we could be a little bit more in conversation about questions you might have, things that have come up, parts of the way that we worked with older adults that would be happy to, or that you would like me to go into a bit more.
Thank you so
I
much,
like
Kate.
to steal these messages. There's also not only
Yeah.
messages on that website, there's also, and I can go back to, you can see it on the bottom here, seriousillnessmessaging.org. There's also images that they have the rights for them. So if you want to take images and put them in your brochure or put them on your website to update it, they've already done the work of doing that for you. So everything there is to be taken.
Awesome. Thank you so much, Kate. This was really informative. And while folks are thinking about their questions, I had a question kind of going back to, I just love how you and everyone who worked on this, you started at a place where you thought this is going to be great and this is going to help people, but then you listened and just found ways to make it better and more accessible for individuals. So I was just wondering your thoughts on how you created that safe space for people to be open and honest about their thoughts about the tool itself in the focus groups or other conversations, and yeah, just how you created that safe space for those conversations to make the tool what it is today.
Yeah. There was a little bit of going to the people who'd been asking for it in the first place. So making sure we're going to people who like they had been eager for it. Let's be sure we get your feedback. Trying to make it clear what we wanted feedback on, of like, we want feedback on flow, format, content, like nothing was sacred here. Like if you don't like the name, if you don't like the pictures, if you don't like the way this is organized, like we want feedback on all of that. And again, giving those prompts of we're going to be removing some of this. Like, what would you take away? What is missing from it? So I think that getting a little bit more specific about what we were looking for, rather than just, what do you think? We just want you to tell us that you like it. Really implying we are going to be making changes. This is your chance to give feedback. There would be times where we would go to people that we knew. So that was a quick, like, somebody that I trust is going to give good feedback. They see a lot of patients in this space. Or we had colleagues who had a lot of life experience, somebody whose dad had just had a major fall. And can I talk to you as the caregiver of what your experience has been? How would this help you in preparing for appointments with him? Or I honestly went to my dad at one point because we were hearing from a lot of women. I was like, I need to do a quick gut check with you of what would this look like before we go to the next round, because I don't want it to pass this phase. And so we paid a lot of attention to the demographics of who we were going to be sure that there was a mix of clinical non, caregiver non, older adult non, type of older adult. I also should mention we had an older adult on the team who's creating the guide with us, but she was in that category of like, I've had the same doctor for 30 years and I've got like one medication, like very well managed healthcare and a long relationship. Well, then let's make sure we talk to somebody who doesn't have the same person or hasn't had consistent insurance throughout, or things, a more complex medical history. So really trying to pay attention to where have we been getting feedback and who's missing. And that was one reason why when we decided to go to, once we were going to focus groups, we specifically wanted focus groups from people in low and middle income cohort, and we picked a variety of racial demographics to look at for that, just to be sure that we were not overly skewed towards a higher income set of answers. Or is this a tool that would only resonate with one group?
Right. That's great. Thank you. Any
There's some part,
other?
but I'll just say with the conversation projects, we've done like 15 versions of those materials. They used to read like they were by a bunch of upper middle class white ladies in New England. Like we've gotten our feedback in the past on other materials. So I think that we knew better this time. But it was interesting just speaking to somebody in Hawaii this week who's very close with the local, somebody who is Hawaiian and very close with the local Hawaiian population, who was saying that some of those phrases, like an extra layer of support, she's like, just say extra support, because an extra layer of support sounds like paperwork. Or like a team to talk to all your doctors. Like, what do you mean the doctors haven't been talking to each other? That's actually more alarming to me. Or like, so you've gotta, don't just take our word for it and assume that definitely works with your unique population. Paying a lot of attention to who it is you're trying to serve, what are the demographics of where you are. To double check that.
Great. Thank you.
And yes, Tamara, you can definitely share the guide with the QIO participants.
Awesome.
They are welcome to be using it. And we hope to have more and more case studies from health systems that are using it and how they're doing it as well.
Great. Awesome. Anju. I hope I'm saying your name right. Anju?
No, you got it right.
Okay.
I know this is really timely for us, I think, because we are working towards creating a senior only primary care program. And, forums is obviously kind of the foundational piece of how we are planning to assess patients. And I think I actually already shared the tool, the link with my team to see if, they find it helpful and how it might be able to include this into our intake. I mean, these are patients we already know, but we are now starting a new program, so we want to do a formal intake. And it was already based on 4M. So I think this will be a good tool for us.
Great.
Yeah.
Thank you for sharing. One thing I realized I didn't make super clear, but where these 4Ms came from is that is like the basis of this age-friendly health system movement, where we did a huge literature scan of kind of the top issues for older adults. And they ended up in these 4 buckets of identifying what matters, medications, mobility, and this idea of mind or mentation, of delirium, depression, dementia, like those 4 buckets. And it's been amazing to hear medical students or residents who say, oh, I can remember the 4Ms. That helps me remember, like, what are the 4 top things I should go over with each patient. And so it's been helpful from the clinical side, but I think it's really helpful from the patient side as well. Albert?
Albert?
Hello. I really appreciate this information because I haven't heard about this in a while. I was injured 21 years ago, and I had a opportunity to have a book called "You Can Do It," and it was actually a book that guided me through my injury. So I had a lot of questions in there and a lot of places that I can actually put information that I was already familiar about myself with. And then if somebody else was to read that information, they can know or understand how to properly care with me or assist me in my care. So I was very appreciative of that book. But then I came back 10 years later and I asked, "Where's the book?" And they don't have the book anymore. And then this book was at Rancho Los Amigos. And when I was 17, I had how you say I had the book, but after years later, the treatment changed. So when the treatment changed, I was curious on how can we still provide this information. And then here you go with this one, which will be very helpful because not only can they assist their doctor with their information on what matters to them the most, they can actually show the doctor that they actually went through the process of having this information available for whoever needs to help them in the future. So thank you so much for having this again.
Thank you. I appreciate that. I think that we say that it's for older adults. I think that it really could apply for almost any age. We know that those forums are useful for older adults, but I think that it's useful for others. The one thing I can imagine some providers getting nervous about is a patient walks in and is like, I got 12 questions worth of comments. And so we're really trying to narrow it down to like, what are the top 3 things that you really want to talk about? But I love your point of it's like you can show your work. I'm not being willy-nilly about deciding that these are the top things. This is what I've been focused on. And I should say, we don't define what older adult is by age in here. There's different groups that would identify that in different ways. There's different communities where the age where they need to engage somebody is a lot younger, and we're leaving that open to the facility that might be introducing it, or to the individual who's reading it. Some of that is just the nature of the Age-Friendly Health System project is focused on older adults. The funders are focused on older adults, but I think that this is a useful tool for many.
Yeah, absolutely. Good question, Albert, and thank you, Kate. Naomi.
Hi there. I just wanted to come back because I said I would think on that. Thank you so much, Kate, for the information and all that is being done at IHI with the Conversation Project. My question from with the continuity care and using this and really seeing, thinking of loved one who had gone from nursing home to inpatient care and was bouncing back and forth, and we were always getting down to, this is what matters, this is who this person is, this is how they are. And so answering my own question in the sense of for the family or caregiver who can utilize it as their continuity of care, and just continuing to update it as they go to different appointments, inpatients, so on and so forth, and then just working with the providers to hopefully get it into the system.
I like that too, if even just kind of coordinating thoughts so that's, oh, what can I do for you here? It's like, okay, here's the 3 sentences that I need to repeat of what's going on with my mom lately. And that may change over time, but I feel kind of organized for each of these appointments and not always starting from scratch.
Absolutely. Well, thank you so much, everyone. Great questions and discussion. I know we're reaching the end of our time together this afternoon. Kate, one last question. Are you interested in sharing the slides? We had a few questions about
I'd be happy
sharing the slides.
So I know I've sent those to you, Lindsay. I'd be happy for you to have them.
Perfect. Okay. So yes, in follow-up, we will share the slides and some of the resources that you had shared with us today too, Kate. So thank you so much. Really appreciate your time and sharing this information with us. And yeah, I think someone in the chat put shamelessly steal everything and definitely utilize it. So thank you again, Kate, and thank you everyone for participating. Again, we recorded this session, so we'll send that out along with the additional resources and slides, and look forward to hopefully seeing you all next month.